thank you, Dr. Muhammad Shawal again. So now is the last part of the talk. It's regarding scleroderma manifestations of renal manifestations of scleroderma, and I would like to hand over to Dr. Voon. Dipersilakan.
Hi, good afternoon. Everyone can hear me?
Yeah.
Hi, my name is Ken. I'm a nephrology fellow from Universiti Kebangsaan, Malaysia. So, first of all, kehadapan Yang Teramat Mulia Datuk Seri Diraja dan Seri Tunku Puteri Indan Safinas binti Tuanku Abdul Halim Masam Shah, izin dapat mempersembahkan tajuk webinar ini iaitu Renal Manifestation in Scleroderma. So, first of all, I want to say congratulations for the official launching of the Persatuan Scleroderma Malaysia, and thanks for having me to share what I know about renal manifestation in scleroderma in conjunction with the World Scleroderma Day 2021. So the outline of my topic is I'm going to talk about incidence of systemic sclerosis, and I'll walk you through the different renal involvement in systemic sclerosis and the significance of the renal involvement. If let's say you have what will happen, what is the impact of the renal involvement in terms of a systemic sclerosis. And I'll touch about scleroderma renal crisis, hypertensive and normotensive, and I'll also touch about ANCA-associated vasculitis. So introduction.
You're not sharing your slide.
Oh,
are you sharing your slide?
Oh, sorry.
Share screen.
Yeah, can you see my screen now? Yeah. Can you see my screen now?
Yes.
Right. Yeah, so this is the outline of my topic. So I will talk about the incidence of systemic sclerosis. I will talk about the different renal involvement in systemic sclerosis and what is their significance when, let's say, you have a renal involvement towards this systemic sclerosis. I'll briefly touch about scleroderma renal crisis and also ANCA-associated vasculitis in systemic sclerosis. So all of us know that systemic sclerosis is a multi-organ involvement. It characterized by thickening of skin and fibrosis of the various internal organs. The exact pathogenesis is still remain incompletely understood, but it was postulated it's actually due to a mixture of vasculopathy and also dysregulation of the immune system. So what are the data we have? So from the United States, the annual incidence is around 1 to 2 per 100,000 individuals in the United States, and the peak age of the onset is between 30 to 50 years old, and is strongly female predominant. What about in Malaysia? So very limited data that we have. This is actually one of the very old study published in 2007 in Hospice Layang Single Center. The patients recruited from 2000 to 2005, only 61 patients, and majority are Malay, followed by Chinese, and lastly is Indian. The peak onset of the disease, the age, right, is about the same, 21 to 60 years old, and also is female predominant. And what about the pattern of renal involvement? As you can see here, there are different presentation when you have a renal involvement. They can come to you with an isolated reduced GFR. They can have an antiphospholipid associated nephropathy, or high intrarenal arterial stiffness, or isolated proteinuria. But again, today the topic of interest is scleroderma renal crisis, which is the main topic for today. And I'll briefly touch a little bit about ANCA-associated vasculitis. So what is the significance of renal involvement? All of us have to understand that up to 50% of our patients here, they are asymptomatic actually, but if you screen their urine, they have proteinuria, and if you check their blood pressure, they might have a hypertensive, and they might have an isolated reduced renal functions. And all of this is very dangerous because they can remain subclinical until very late stage of the disease. And this is one single large cohort study done in China. So the significance here is, if you look at them, if they have a CKD, they have a renal hypertension, proteinuria, renal crisis, as long as the renal is involved, they have a very large mortality rate, which can bring down the survival rate. If you don't believe in the Chinese cohort, if you can look at the multi-nation cohort, this is actually from Canada, New Zealand, and Australia. As long as the renal is involved, they have a renal crisis, you can look at the mortality rate is higher if the kidney is involved. However, the leading cause of death in scleroderma is still due to a pulmonary fibrosis and a pulmonary artery hypertension. But if you look at the 1 year post-scleroderma renal crisis outcome, is still very poor. Up to 30% of the patients will die from a disease, and up to 25% will end up with hemodialysis after the scleroderma renal crisis. So, what is the incidence of a scleroderma renal crisis now? If you look at the US, they mostly affect the population with a diffuse scleroderma instead of limited disease. So in US, 10% of them, 10% of the diffuse scleroderma, they might have SRC, and 2% of the limited disease, they will have a SRC. If you look at the Europe population, 5% of the scleroderma patients with a diffuse involvement, they might have a scleroderma renal crisis, and 2% of the limited disease, they will have a scleroderma renal crisis. In Japan, the prevalence is reported as 3.2% of the scleroderma population, they will have an SRC. But the good news is the prevalence of SRC is decreasing. Perhaps they are related to the early initiation of the ACE inhibitor or also the early detection of the disease. And another good news is in Malaysia, this was taken from a previous study I mentioned from Selayang Hospital. If you look at the renal crisis, it's actually none of them present with a renal crisis. So it's indeed a good news for nephrologists. That means in Malaysia, nephrologists are jobless in terms of the scleroderma. Just a joke. Okay. So you look at the pathogenesis of the systemic this scleroderma renal crisis. It's all started with an endothelial cell injury. It's postulated that it's due to the activation of the endothelial cell antibody, and it further activates the inflammatory cycles. Then the type 2 helper T lymphocyte is activated, your cytokine production, you have excess collagen accumulation, and so on. Then it leads to the artery intimal layer proliferation, and then cause a vessel luminal narrowing, and it's so-called the renal perfusion. And on top of that, when a scleroderma patients, they also have this Renal phenomenon, not only in your fingers, they can also occur in your renal vasculature. So this on and off intermittent episodic renal vasospasm, they can cause a decreased renal blood flow, and not finally, they have a hyperplasia of the juxtaglomerular apparatus, then increase the renin production. Then when you have the activation of the RAS system, it will lead to a malignant hypertension. And this is actually a vicious cycle. And then this malignant hypertension can cause a further endothelial cell injury, and this cycle will go on and go on until you get this end-stage renal disease. So this is an arteriogram. You compare with a normal patient with someone with SRC. So if you look at the left side, the vasculature is well perfused. There's no filling defect. But if you look at the right side, you can see there's a very nicely illustrated here. The renal vasculature is actually very reduced, and there's a multiple filling defect, as you can see if you compare to the left side. So this is exact what happened in the patient with the SRC. So for the biopsy changes, so usually SRC mainly involve vascular vessel lesion. Very rarely you will see a lesion in the glomerulus, which I'll explain later why. So what happened is the main changes actually occurs in the vessels. So what happened, you can look at the left side, this is actually in the early stage, you will see the deposit of this myxoid material in the lumens of the artery. This is during the early stage. But eventually, the late stage of disease, right, you will see all this concentric lamination, and this is a classical, we call it onion skin lesion, which is a very common question that comes up in the master exam. So I think you should take a look at it and look and remember how it looks like. So just how I mentioned, right, mainly it's a vascular lesion. Glomerular changes is very confined to these ischemic changes. Imagine now all of these arteries, they are being stenosed, so the blood perfusion to the ground is reduced. So the typical changes, if you can see, is you can see this reduced perfusion to the kidney, to the ground. So you see the ground. The normal ground, right, the endocapillary, they should remain open, but in here they are all collapsed because due to the ischemia. So you see when the ischemia happens, so all of this looks like is like wrinkling and shrinking and being pulled to the center. So you see all of this ground, right, is like a dying flower, you know. Imagine the grounds, right, they should be, the normal ground, the endocapillary, they should be open like flower blossom. But in here, all of these endocapillary, they remain occluded because of the ischemic collapse of the glomerular stuff. So another typical change that you might see in during the kidney biopsy is this two is the Seward-Jones stains. So you look at the endocapillary, right? You see all of this pinkish or sometimes a reddish deposit. These are all thrombined. So when you have an endothelial injury, so the blood flow towards the endotheliums, they are being occluded and a platelet clumping. So the thrombin is actually formed inside the endothelium. So they can actually capture the thrombin in the biopsy when you take a biopsy of the patients. So this is a classical changes of a TMA as well. So if you see such lesion, they can be part of the scleroderma renal crisis, but you might have to think about other differential cause of TMA, thrombotic microangiopathy, such as HUS or TTP. So the clinical presentation of an SRC, it can be a multifaceted. It can come to you with a neurological manifestation like seizure, hypertensive encephalopathy. They come to you with an acute left heart failure or pulmonary edema, or they come to you with bloody vision with hypertensive retinopathy and AKI as well. But if you want to diagnose the SRC, it's quite difficult because as I mentioned, they can come to you with a different presentation. And on top of that, sometimes they can come to you with a normotensive because they have a hypertensive SRC, they can be a normotensive SRC. So if you want to diagnose a SRC, it really is a challenge. So just like this picture, when you see a patient, you suspect of a SRC, you should think broadly, not really confined to a certain part of the elephant here. So this is a recommended algorithm to diagnose an SRC. So the blood pressure must be, systolic blood pressure should be more than 140, diastolic pressure more than 90, or there's a rise of the systolic blood pressure of more than 30, or diastolic blood pressure more than 20 above the baseline. With acute kidney injury that fulfill the KDIGO criteria, and there must be evidence of a TMA with anemia, with a full blood picture showing the evidence of a cystocytes, thrombocytopenia, and there is a lab evidence of a hemolysis like elevated LDH, radiculocytosis, and a low haptoglobin, and as well as a negative Coombs test to rule out hemolytic anemia. And you must have some other evidence of the other organ damage, like a heart, like a neurological manifestation, or lung manifestations. And of course, if you can biopsy the patient showing the vascular changes, that would be the best, but there are some caveats behind the biopsy, which I will further elaborate later on in my slides. So what are the risk factors for someone to develop SRC? So there are a few well-documented risk factors here. So the first one, if you have a rapidly progressive skin thickening, most of them, 75 to 86% of them, right, they might develop SRC in the first 4 years of disease. So it's actually a very good marker to tell you whether this patient have a high risk developing an SRC or not. And secondly, if let's say you detect an nDRNA polymerase III, this antibody, it can tell you whether they are having a risk of getting SRC as well. They are reported 9.4 to 59% of these patients have an nDRNA polymerase III positive, they might develop SRC. And in the Austrian cohort, if let's say you have you without this antibody, then you have a lower risk of getting SRC. The risk is like 2%. So they definitely have a high negative predictive value to rule out SRC. Another risk factor is if you have a presence of a tendon friction rub, which will palpate the joints. If you hear some crepitus, this is also one of the risk factors for you to develop SRC as well. And next, if you have a prolonged exposure to corticosteroids, defined as more than 50 milligrams of corticosteroids per day in the past 6 months, this is a well-recognized risk factor of SRC. The reason is behind this is because they promote an endothelial dysfunction and inhibit the prostacyclin production, which in turn increase the ACE activity in the VAS system. And lastly, if let's say from a gene study, you have a HLA-DRB10407, HLA-DRB11304, all these are the independent risk factors for developing SRC as well. So what are the differential diagnoses when someone comes to you with SRC? They can actually be ANCA-associated vasculitis, They can be a malignant hypertension. They can be overlapping with some other connective tissue disease like SLE. They can be drug-induced. Bear in mind that penicillamine is one of the old medication to treat this scleroderma in the past, but this penicillamine definitely can cause renal injury. And don't forget, if it's someone with calcineurin inhibitor, they can cause AKI as well. And lastly, not to forget the thrombotic microangiopathy TMA, such as HUS or TTP. So kidney biopsy, not to say that they don't have a role, but you have to bear in mind that most of the populations with SRC, they come to you, they will have a certain degree of thrombocytopenia, and the blood pressure is always highish. It's quite dangerous to biopsy such patients because of the risk of bleeding. So if, let's say, you are in a doubt whether this patient is having other differential diagnosis like ANCA or like TMA, then you might need a biopsy to help you. But other than that, right, you maybe can send some of the investigation like ANCA level. You can send this ATOM13 level, the antibody against 13. You can send this complement H, complement I, or the complement H antibody. But I'm not sure whether Malaysia can do it or not. I think we should send it in Finland for the complement H antibody. Okay, what's the principle of management here? So if you want to manage a SRC well, the principle of management is early detection. Because the early detection, it can prevent the irreversible kidney damage and death. And it's also important to prevent some other complications like hypertension, retinopathy, and also pulmonary edema. And the next principle is timely initiation. Okay, I use the word timely. Okay, it's not early. I'll mention why. You should start your ACE inhibitor at the right time, not early. Okay, because if you start too early, it wouldn't bring any benefits, which I will elaborate more in the slides later. So if, let's say, the blood pressure is not controlled after you start the ACE as a first line, you might add in a calcium channel blocker as a second line and a diuretics or alpha blocker as a third line. And ARB can be used only if the patient is intolerable to ACE inhibitor. And what are the preventive measures? Again, if you suspect the patient is having an SRC based on the risk factors that I mentioned just now, then you can actually review them more closely. You can see them more shorter interval. Instead of 3-4 months, you can actually see that every 1 or every 2 months to monitor the BP, to monitor the proteinuria, and also the kidney functions. And if you think necessary, you can actually refer to our friendly nephrologist. I'm very friendly, to be honest. So again, prophylactics, this ACE inhibitor, they actually show no benefits and actually they show harm. Okay, again, I will show you in the later slide. So just now what I mentioned here is if you see a patient in outpatient, you can actually treat the blood pressure by taking your sweet time, start the ACE inhibitor, then you add on some other agents to control blood pressure at your pace. But if you're seeing someone inpatient in an emergency, if they come up with you with the hypertensive emergency, then you might need to bring down blood pressure aggressively. So it's recommended to bring down reduce the MAP by 10 to 20% within 1 hour. You target the diastolic blood pressure 100 to 110 within 24 hours. And you need to use the oral therapy plus minus the IV vasodilators. And you treat the other manifestation as well. If they have seizures, you give anti-epileptics. If they have a pulmonary edema, you will give the diuretics. If, let's say, they present with a tachycardia, then you need to refer to the cardiologist because beta blocker is relatively contraindicated. I'll explain why later. If they have AKI, oliguria, then you can refer to us. We can nicely do the job for you. So a little bit interesting facts about this systemic scleroderma renal crisis. So if you look at this very old study done in 1973, this paper is actually older than me. For those patients, because before 1970s, there's no ACE inhibitor available. So if, let's say, someone comes to you with a scleroderma renal crisis, right, the outcome is very bad. As you can see, this is a normal population. This is the population with the scleroderma, not too bad, but as long as they have a kidney involvement, you can see the mortality is very, very high. After all of them, they'll die within 1 year. So it's a tragedy if you get the scleroderma in 1970. And the treatment available in the 1970s, again, is very limited. So you see what you can do is you can do dialysis. You even need to do a nephrectomy to control hypertension. And you can think about venous transplant in the past. But all of this, right, is actually not so effective. And not until 1979, there's a first case report being used involving this ACE inhibitor, then more and more people looking at the ACE inhibitor. Subsequently, there are more solid evidence by using an ACE inhibitor to treat the scleroderma renal crisis. As you can see here, they compare the ACE inhibitor and without ACE inhibitor. Of course, the population with the ACE inhibitor, they have a higher survival rate. Okay, why ACE inhibitor? Again, this is actually just now what I showed in the previous slides. So because when you have a scleroderma renal crisis, you have a hyperactivation of the RAS system. So you are giving an ACE inhibitor, you are trying to block the renin, the RAS system. So of course you can actually retard all of this vicious cycle, and then you might actually halt the development of the scleroderma renal crisis. And I just need to make a disclosure here. I don't have any benefits by showing a captopril here. It's just a very nice diagram. So I do not earn any single cents from showing captopril here. But you can use any form of an ACE inhibitor as long as they belongs to an ACE inhibitor. So this is a paper why I mentioned just now, we shouldn't start ACE inhibitor as prophylaxis. We should use them when we diagnose someone with a scleroderma renal crisis, but not to use too early as prevention. As you can see, this paper published in 2020 from a U-Star analysis. These are the population with a scleroderma. And if you start with the ACE inhibitor too early, you see this is a red color line, right? That means you start the ACE inhibitor for them without any evidence of scleroderma renal crisis. The incidence of them for them to develop SRC is actually higher for those patients that are not started with the ACE inhibitor. Indeed, it's very odd. So it's recommended not to start ACE inhibitor unnecessarily unless you think he or she is actually having this scleroderma renal crisis. Okay, what to do? So if left blood pressure is high, then what are the agents to be used? You can use CCB, but CCB will not affect any incidence of the SRC. But if you use ARB here, SRB, they have some not very significant, but you can see for those patients with hypertension, no evidence of SRC. If you start ARB for them, actually they have a reduced incidence of the SRC. So the take-home message is if you see someone with a hypertension in the scleroderma population, maybe you can actually use ARB, but definitely you need more study for this. So what about beta blocker? Just like I mentioned, we shouldn't use beta blocker, but if you look at the physiology, if you start, because beta blocker, if you have a beta activation, you will increase the renin secretion. So beta blocker can actually decrease the renin level. And indeed from a study, if you start beta blocker for someone with hypertension, you can bring down blood pressure, you can bring down a renin system as well. So it actually works well and fits well in our population of the SRC. But because if you start beta blocker, they will actually worsen the vasospasm, which will worsen the Reynolds phenomenon. So whether to start beta blocker in our SRC population is actually remains something to debate. So what about plasma exchange? Although plasma exchange have been proposed as one of the treatment for TMA, but in case of SRC, they haven't shown any efficacy and also any evidence. So it should not be recommended unless you are treating someone with a proven TMA, like what you call it, like a TTP. You send an Adams level 30 is positive, or you suspecting someone have an atypical HUS, then maybe plasma exchange might have some role. But in the case of a pure scleroderma renal crisis, plasma exchange definitely has no role for the time being now. So another novel agent, complement 5 blocker. So in certain case of SRC, if let's say they are involving this complement system activation, you can use this complement 5 inhibitor, which we call eculizumab. So they are a humanized recombinant monoclonal antibody directed against the complement component 5. And this drug is going to inhibit the generation of C5 A and also this terminal ATAC complex. So I hope you still remember what we learned before. This is the complement system. As you know, there are 3 different pathways, but we only focus classical and alternative here. So you can see the common pathway in the end will lead to the activation of a C5. So this is a terminal pathway. When you have the C5 activation, then you lead to the activation of this terminal ATAC complex. Then they will further activate multiple cells and it lead to the endothelial inflammation. That's why the C5 inhibitor, there's a role for them to inhibit all of this endothelial inflammation. So when you use the eculizumab, C5a inhibitor, we are actually blocking the pathways here. So you are trying to inhibit all of the endothelial inflammation in the hope that it can reduce all the inflammation. So in case of a severe AKI, if you oligograde AKI, you can refer us for do a dialysis. So there are some points I have to highlight here. So if let's say someone comes to us with oligograde AKI on top of the scleroderma renal crisis, and if let's say we start them with the hemodialysis, some of them, right, they actually need 6 to 24 months to get renal recovery. So they have a late recovery, even though they have an initial stage of very bad AKI. So if let's say you want to transplant in this group of population, it's recommended to wait until 2 years because they might actually recover spontaneously in 1 year time or 2 years time. So you might need to give some time before you talk about renal transplant. And the data from Australia, New Zealand, and Europe shows that if let's say you have a end-stage renal failure secondary to systemic sclerosis, generally they do quite bad if you compare with other causes induced end-stage renal failure. But if let's say you can offer them renal transplantation, renal transplant gives you a better survival compared to long-term dialysis. So this is the data that I get from UNOS. So the recurrence of a disease after transplant is only 6.7%. It's not too bad. So I have touched the hypertensive scleroderma renal crisis. Now I will touch the normotensive scleroderma renal crisis. So it only occurs in approximately 10% of patients. Usually they are associated with a worse prognosis, a high mortality rate, and also an earlier need for the renal replacement therapy. And among the population with a normotensive SRC, if they have a severe anemia, thrombocytopenia, and pulmonary hemorrhage to begin with, they will do very bad. So another one is the ANCA-associated vasculitis. So this diagram taken from a Chapel Hill classification. So they have different type of vasculitis, but when we look at the ANCA vasculitis, we are actually talking about from here, the small artery up to the veins. So there are different types of the ANCA-associated vasculitis, like MPA, GPA, or EPGA. So all of this is actually a very specific topic. I think you can, I can't finish in only one talk. You know? They are actually a very own topic by themselves. You know? So I'll just touch a little bit about them. So this ANCA-associated vasculitis is rare in a systemic sclerosis. It's found only up to 9% of patients. And most of the ANCA-associated vasculitis in this group of patients, they are described as a normotensive. And they are also MPO positive. And in contrast to a classic scleroderma renal crisis, the majority of cases, they occurs in a cutaneous limited systemic sclerosis rather than a diffuse type of the systemic sclerosis. So this is a contrast. So these are the points for you to differentiate between whether it's ANCA or whether it's a SRC. If let's say it's a normotensive, maybe it's ANCA. If let's say you send the ANCA level come back as positive, then maybe it's ANCA. Or if that patient is actually having this cutaneous limited systemic sclerosis to begin with, then maybe they are not SRC to begin with. So, but of course, if you can have a renal biopsy, that would be the best to distinguish between the SRC and ANCA-associated vasculitis. Okay, I think that's my last slide, and thank you.
Okay, thank you Dr. Ken. Yang Teramat Mulia Datuk Sri Diraja Tan Sri Tunku Puteri Intan Safinas binti Tuanku Abdul Halim Muazzam Shah, saya patut memohon untuk kita memulakan question and answer session. Okay, if anyone would like to ask any questions to any of the panelists,